Okay, let's talk about innovation in the setting of cardiac arrest. So we know that high-quality chest compressions, coronary perfusion pressure, and compression fraction are all what drive survival. If you're stopping compressions for prolonged airway attempts, you are hurting the patients. With that said, a properly placed ET tube may still have some advantages when it can be placed by experienced providers without sacrificing CPR quality, or at least that's my opinion. Supraglottic airways are excellent devices. They're fast, they're simple, and they're often a really good initial choice early on in the resuscitation sequence. As we know, cardiac arrest patients frequently have poor lung compliance, obesity, pulmonary edema, aspiration, bronchospasm, chest trauma. All of those things can increase airway pressures. As those pressures rise, supraglottic airways may be more prone to leaking compared to a cuffed endotracheal tube. I have yet to find a study directly stating this in the context of cardiac arrest patients, but information regarding seal pressures can be reasonably extrapolated from other airway literature and applied here. More leak means less effective ventilation, worsening oxygenation, and potentially worsening blood gases. The cardiac arrest airway data from the University of Minnesota show that patients managed with supraglottic airways during prolonged refractory cardiac arrest demonstrated lower pH, higher CO2 levels, and lower oxygen levels compared to those managed with endotracheal tubes. Now, this isn't just an argument against SGAs. Once again, we think they're outstanding tools and they save lives every single day. The point is that airway management during cardiac arrest is more nuanced, at least in my opinion, than SGA good and ET tube bad. Not every EMS system is the same, as we know. Training, experience, equipment, staffing, and procedural exposures all matter, and they vary a little bit with each EMS system. This is where I think we need to be careful with how we interpret the literature. Too often, people read abstracts and conclusions while ignoring study limitations. Data has to be interpreted carefully and applied within the context of a system's training standards, operational capabilities, provider experiences, and patient population served. In a highly trained ALS or critical care system with experienced clinicians, video laryngoscopy, and a strong emphasis on minimizing interruptions, it is my belief that endotracheal intubation can still be performed safely during ongoing CPR. Would love to hear your thoughts and opinions. Please post them below. And thank you for listening. Have a great day.